called The 5 Whys and 1 H of Breast Cancer Metastasis, New Insights for Recent Research. So I am going to introduce our speakers, but let me tell you a little bit about the session first. Our next session dives into new insights into breast cancer metastasis. We're pleased to welcome Josh Newby and Dr. Xiang Zhang. We will start with a brief advocate introduction by Josh, and then we will dive into, and these are the 5 whys. I didn't know what it was either. Who, what, when, where, why, and the H is how of metastatic breast cancer with Dr. Zhang. I'll briefly introduce both of them, and then we can start the session. Josh Newby. Josh Newby is the co-founder of Teresa's Research Foundation, which he established with his mother, Teresa Newby Harpole, who passed away from metastatic breast cancer. He is also a senior community relations and special events associate at the Lester and Sue Smith Breast Cancer at Baylor College of Medicine. As a BRCA2 gene carrier and a graduate of NBCC Project Lead, Josh is dedicated to fostering collaborations between advocates and researchers. Dr. Xiang Zhang is the director of the Lester and Sue Smith Breast Cancer and the William T. Butler Endowed Professor of Baylor College of Medicine. He also leads the breast cancer program at the Dan L. Duncan Comprehensive Cancer Center. Dr. Zhang's lab has made groundbreaking contributions to understanding metastatic breast cancer, focusing on tumor microenvironment interactions and immunotherapy. His work has been published in leading journals, and he has received numerous prestigious awards for his research. Dr. Zhang is also a key member of the NBCC Artemis Project, and we are thrilled to have him with us.
I was so grateful that Dr. Xiang Zhang was invited to give this talk. This talk is a real honor amongst the research community to get to give this talk, so you guys know. And a lot of our dear friends have gotten to give this talk and always share about how much they enjoy this experience. So when he got this invitation, it just meant the world. And then Michelle was kind enough to ask me to give a brief introduction. And my introduction was kind of about this new era, and I just want to kind of preface and say that this new era is talking about metastatic research, and that's the area that I now focus on after many years of kind of larger advocacy work. But that new era is possible because of so many people that are in this room, and so many people like Shirley Mertz and Musa Mera, who really helped pave the way. All the group that NBCC has done. And then now the reason we're able to go into this new era is because of all this new advances in research, and then because of patient advocates like you who are in this room. So we're really heading in this new direction, and it's super exciting. And so what happened was people would be like, why are you up here? How did you get to Texas if you don't know me? Or what's going on with this guy? Many different hats. So long story short, my mother, as they mentioned, passed away in 2013, and we had started a foundation. She's from St. Louis, and just so happens I met Dr. Matt Ellis. I'm not sure if Rosanna's still in the room, but he was recruited to St. Louis, to Houston. To work at Baylor College of Medicine. And there's one thing you know about Dr. Ellis. The one thing that he does is he connects people. And so the first thing he did when I arrived was he's like, you got to go meet this guy, Sean. I think you guys are a good pair. Well, I guess he was right, because we've now been working together for 10 years. And it has just been a complete honor to get to work with him. And we've worked on a lot of different projects together. And so one of those projects is, the first project we ever worked on was his Era of Hope grant. And Era of Hope, if you're not aware, is an award given out through the Department of Defense, and it's for young investigators. And it's really had a monumental impact on so many people's careers. And probably I would say the biggest message, if I could just leave before Sean talks, is just the unintended benefits of things that happen, okay? So that award is great, and what's so special about DoD is that patients review grants, and that's really great, and that is so unique. But the other thing, the other intended benefit that happened out of all that work is that those researchers saw the value of working with patients. And that has changed the world. That's why I'm up here now. That's why we're doing this. And so that's really led us into this thing. And so I really recommend you also to check out the Artemis Project. So people that get Air of Hope Award, they get invited to be a part of Artemis. Well, yes, some people might say, well, Artemis focuses on this or that. Well, Artemis has a long-term unintended benefits of other things. For example, I helped run a conference with Xiang called the Metastatic Breast Cancer Research Conference. A lot of what's learned at Artemis and how that meeting is conducted, we then apply it to our meeting. So there's all these kind of things that happen and are kind of trickle down that are just really unique and special. But yeah, I really recommend watching the Artemis video that Beth Emery did with Dr. Cyrus Gajar, again, another Air of Hope scholar. And then I guess a few other quick things. Project Lead. I really encourage you guys to participate in that if you haven't, or if you have, write letters, encourage other advocates to do it. If funding's needed, don't hesitate to reach out to me. Also, if you're writing grants for people, reach out to those institutions. We have funding, for example, at Baylor to help people out. We have, different opportunities and can connect in that way. But it's a great program. I'm staring right at Judy. I can kind of see you through the lights, but I did my Project Lead with Judy, and it's a memory that will forever stay in my heart because Judy was going through a lot at that time, and because of that experience there, she's here with us today, and it's something I always share her story, and been so grateful for her to share her experience. And then just lastly, we have our SPORE at Baylor. Sharon Anderson's in the room. Julia was in here earlier. They're on that. Bonner Cutting used to be there. And so there's a lot of different opportunities to get involved in advocacy. And then just lastly, with our conference that we do, we'll be in Pittsburgh next year. And when Dr. Eltz and I founded the conference, it was a CME meeting. And now that Dr. Xiang Zhang and I run that meeting with Dr. Alana Whelm, who's again another Air of Hope scholar involved in all this. So you can kind of see how these things are all connected, right? And so the meeting is no longer CME, it's a research-focused meeting, and because of that, what's been happening over the last 3 or 4 years is that why Dr. Xiang Zhang has been really focusing hard for us on building up the research community on that side. We've been growing the patient advocate side and research collaborations inside of there, and so I really encourage you to participate in that meeting and learn more about it. And so with that, I'm gonna take it over to Xiang. Thanks.
Thanks. All right, thank you, everyone. It's really my pleasure and honor to be here. My name is Xiang Zhang, as already introduced. I have been studying breast cancer for the past 20 years, since the training phase. So my lab predominantly work on breast cancer, metastasis, tumor immunology. I like to also share that my mom is a breast cancer survivor. She was diagnosed in 2012, in the summer of 2012, which was a very transformative experience for me. I started to really try to make my research from patient's perspective because I always worry my mom's cancer will come back. That level of anxiety really is one of the driving forces for me to push my research forward. What I'm going to do today is I'm trying to get some basic knowledge together with some recent discoveries, not just from my lab, from many other labs in the field. I'm trying to kind of synthesize them, try to tell you some of the new insights. Most of these insights are still at very early stage. It's a discovery. How to translate these discoveries into clinical practice is what we are trying to do, and we definitely need your help in that process. And that's also one of the missions of NBCC and Artemis project. So a lot of this is also got inspired during my participation in those events. So how do we shift? Okay. So this is what a cancer biologist view metastasis from several decades ago. We know that this is a multi-step process. We know it's very complicated. From this picture, you can appreciate that for a metastasis to occur, cancer cells need to first leave the primary tumors and get into the blood vessels and travel in blood vessel, arrive in the distant organs, and kind of do a reverse migration outside from inside the vessel to outside the vessel, and where they may stuck in some other organs. Many of them die. Some of them may eventually thrive, become a secondary tumor that kill the host. We know that 90% of the breast cancer-related deaths are caused by metastasis rather than primary tumors. This is already pretty complicated, but it's still oversimplified, right? If you're looking at this, you don't have the sense of the 5W and the 1H. You don't have the kinetics of the process. You don't have where exactly do these cells go. There's a very generic secondary organ there, but does every organ have equally the opportunity to receive metastases? Do they have equal properties to be affected by metastasis? A lot of questions are not reflected in this. So what I'm trying to kind of get organized, all the information I'm going to tell you today, is through these questions. These questions are not answered by the first slide. The first question is when. When does the metastasis occur? When this process, leaving primary tumor, arriving distal organ, when this process occurs, and what's the implication of that? And that is a relevant, maybe the foremost question we are encountering in that answering that question is this dormancy phenomenon that we now know very well. We know it occurs, but we know very little about the underlying biology. I'm also going to talk a little bit about where, so which organs are the most likely targets of metastasis, and this very surprisingly have vary from patient to patient, and we also have some more recent insight of that. And I'm going to talk a little bit about what we learned recently about which specific cancer cells may contribute to metastasis, and what will that entail? Is there any other cell that also participate in this process, or is it just the cancer cell themselves? I'm going to give you bone metastasis as an example of to explain how cancer cells eventually take over an organ after they arrive there. Because my lab focuses on bone metastasis the most, so I feel more comfortable to use bone metastasis as an example. And because of the limitation of time, we are not going to tell you everything else, but other metastases are also very important, like lung metastasis, brain metastasis. And finally, I would like to have a discussion with you on why metastases are so difficult to treat. We can easily resect primary tumor. We can treat primary tumors, but the metastases are very difficult to cure, although we now have some new insights as well. So let's start with this dissemination, the timing of the cancer cells that leave primary tumors. These are two articles in the literature. One of the authors actually attended the Artemis meeting last year, Dr. Klaus Pantel, and he together with another investigator, Julio Aguirre, he's at the Einstein Medical Institute now. So these two labs together published two papers, really kind of nailing the fact that the metastasis can occur very, very early on. So even before the primary tumor diagnosis, we kind of know this clinically from a long time ago, but they prove it in the preclinical models and using patient samples. And what's striking about this is even at DCIS stage, metastasis may already occur. It does not always occur, but in some cases, DCIS may already have the ability to migrate outside of the breast and reach other organs. And this paper really provides some molecular insights into this process and really lay the foundation of further studies. Okay, so this is something, it's not totally surprising. It's always good to see progress in the research side. In the clinical side, we know this from a long time ago because we all know when patients were first diagnosed to have breast cancer, those primary tumors are usually immediately removed, right? And after the removal, there appear to be some tumor-free period of time, which is highly variable between patient to patient, and eventually a minority of patients will have the tumor back to different organs. So if you look through this process, I think it's also clear the only possibility for this to happen is when you do the surgery, there are already cancer cells escaped from primary tumor so that they are not taken care of by the surgery. And adjuvant therapies afterwards are trying to kill them, right? We use adjuvant therapies, chemotherapy, endocrine therapy. The purpose of those therapies are trying to hit those hidden cells that already leave the primary tumor and are left behind by the surgeries. However, they're not doing a good enough job. Some cells in the distal organs still manage to survive, and they survive for a pretty long time, and after that they become overt metastasis. So if that lead us to this topic of metastatic dormancy, which I think is one of the central challenges we are facing in the clinic, trying to completely cure breast cancer. And if you look at the left figure, I hope there's some information is cut off, but that's okay. Let's see if I can have a pointer. Well, let's see. If the left side, you are looking at the risk of developing metastasis over time, right? Here, ER negative, ER positive tumor patients are divided, and they clearly exhibit different kinetics of developing metastasis. So whereas the ER negative patients will have a much higher possibility to develop metastasis within a few years, the risk will drop after that period of time, very evidently. But the ER positive, the risk of ER positive tumor to metastasize persists, a long time after the therapy, the surgery. And so definitely ER negative versus ER positive have different mechanisms of metastasis. And on the right, you're looking at the number of lymph nodes at diagnosis and also correlate with the risk of recurrence going forward. And it's very, in a very straightforward manner. So the more lymph node involved, the more likely the metastasis will come back. So all of this suggests that so we need to kind of look at different situations a bit differently, especially for the ER positive and the ER negative situation. And why cancer cells can stay viable in distal organs. Why, especially in ER positive disease, you see this persistent risk of recurrence. So these cancer cells find a way to keep themselves alive in a very foreign environment, right? To them, their home is mammary gland, but now they are in a different environment. They manage to survive, not only survive the environment itself, also survive the adjuvant therapies, right? So that has to engage, they have to use a lot of different mechanisms, as we would imagine, to achieve that. So there are a lot of the hypotheses, and some of them are listed here. For instance, we used to think the reason that they are viable but not growing back is because of the lack of blood vessels. So the day that they learn how to evolve to generate, to attract blood vessels, and they will now gain momentum to thrive, to kind of outgrow. That's one of the hypotheses. And another hypothesis is the immune system, the interaction with the immune system, right? So the immune system can keep these cells under check. So whenever the cells try to grow, immune cells can detect that growth and can eliminate those cells that tend to proliferate. However, when the immune system is weakened, or if there's some other perturbations to the health, they provide some opportunities for these cancer cells to take the advantage of that and outgrow. So there are different hypotheses that are already flown in the field. And let's switch to what we learned from more recent literature. By more recent, I mean less than 5 years, within less than 5 years. And these are very recent literatures, just published within the past 5 years. And on the left, I used one of the studies recently published by Dr. Saras Gajjar on cancer cell, which is a leading journal as well, in the lung. And there, the conclusion is the reason that these cancer cells can get away from the immune cells is because they're so rare. And our immune cells only have so much ability to detect rare cells. And this is a number game. And if we don't have enough immune cells surveillance the organ, we may bypass, we may miss the cancer cell that's hidden there. But however, if you know what these cancer cells are expressing, how immune cells can recognize these cancer cells, you can increase the number of the right immune cells to eliminate those dormant cancer cells. So this is one study suggests that some of the dormancy is because of a passive escape. It's just because these cells are so rare. And the immune cells we need to increase the appropriate immune cells in order to detect and kill those cancer cells. On the right is even more recent paper. It published by Dr. Julio Guiso, the same author I just mentioned in the previous slide. So there, it's a little bit different. So what's discovered there is also in the lung. So instead of these cells are overlooked by the immune system, this is suggesting there are some cells like macrophages, like alveolar cells in the lung, which is a different type of macrophage. The normal job of this macrophage is to scan the tissue and trying to find infections and respond to that. But in this case, these cells are localized very closely to these dormant cancer cells and establish very close interaction and keep these cells sleeping. So when there are perturbations from the environment, such as inflammation, such as injury, and this interaction may be weakened, and then the cancer cell may get a chance to escape that control of the alveolar cells and become proliferative. So these are two different mechanisms. One is a simple kind of, the number game, the rarity of the cancer cell exceeds the detection limit of our immune system. The other is there's other cells in the body that actively maintain dormancy of cancer cell. All of these mechanisms may be at work in some situations. What we need to do is to learn as many examples as these and try to find something in common that we can use as targets to change the situation. Another two papers recently published along the same theme. So on the left, this was published by Dr. Michaela Agiblad now at Johns Hopkins. She found that the smoking will wake up the dormant cancer cells in the lung. So that is through that stimulation of some neutrophils, which is very interesting. And this is one example of how this bad habit can cause even worse, consequence. And on the right is the study from my lab. So we found that fractures, pathological fracture, sometimes can stimulate growth of metastatic bone metastatic cells. So we also identify some molecular mechanism that we may be able to used to combat this connection. So, but the common theme from all of this study is the tissue turnover, the homeostasis of the organ that hosts these metastatic cells sometimes may play roles in determining the fate of these cells. So any kind of fast turnover of the tissue may break some balance that these dormant cells used to be. And then they cause the change of trajectory of these cells. And if there's in a bad luck situation, these cells may take off to grow. Of course, in each of these studies, they are following up research on how to therapeutically target this process. And the researchers are communicating constantly, and we know each other's hypothesis, and in a meeting like Artemis, we kind of exchange our ideas and we form joint projects. Okay, so I think let's talk about the organ of tropism. So where do metastases tend to occur? Which organs? And I will spend relatively less time on this. So it's very interesting to see that different cancer types tend to have different spectrum of organ they affect. It's like in breast cancer, we know bone metastasis, lung metastasis, brain metastasis, liver metastasis are among the top 4 organs that tend to be affected by breast cancer. In prostate cancer, for instance, the situation is much different, and you have predominantly bone metastasis in prostate cancer, 70–80% of cases. And in lung cancer, you're looking at a similar range of organ, although we know lung cancer usually are much more aggressive. And if you divide our breast cancer into subtypes, you start to realize that not only the kinetics of ER-positive, ER-negative patients are metastasis different, and they tend to develop metastasis different organs as well. And you're looking at a bunch of numbers. I think this is very difficult to read. Please focus on those bold ones, okay? Those bold ones. And on the leftmost column, you're looking at different subtype of this breast cancer. You probably are very familiar with luminal, basal. These are approximately the same concept as ER-positive, ER-negative, as well as a HER2-positive, right? And the first row, luminal A, was all ones. That's because everybody else, every number else is normalized to this number. So everybody else is dividing this number. So this number is set as 1, 100%. So when you look at the first set of data, the brain, for instance, you realize that the HER2-positive and basal-like breast cancer have 3.6-fold, 5.3-fold, 2.1-fold higher chance to develop brain metastasis compared to luminal A, okay? And so on and so forth. So this is how to read this table. But I think if you focus on bone versus the other organs, and you focus on the difference between basal and the luminal A, you realize that they have very different organ distribution. Like the luminal tumor, although it have much less capacity to metastasize to other organs, it does have a higher chance to metastasize to bone. Okay, so the bone tropism is very evident in ER-positive, the luminal-like tumors, but it's less so in the basal and HER2-positive tumors. And this is another way of looking at the same data. On the left, in the A panel, you're looking at overall metastasis to any organ, and you're looking at ER-positive, ER-negative, divided as a function of time, the probability. You see this curve keep going down. The red curve is ER-positive, the green curve ER-negative. The green curve has a much faster rate of decreasing in the early time point, but the two curves finally kind of meet each other, after 6-7 years. So, and that difference is exactly caused by, although they metastasize in a different rate, the metastasis of different organs, they eventually kind of have the similar rate of metastasis. And the bone metastasis is one of the reasons why ER-positive breast cancer keep developing recurrence. So bone is a very preferred organ for ER-positive tumors. And I will talk a little bit about the mechanism and the treatment of bone metastasis in a later session. Clinicians and scientists have noticed this from century ago. So even century ago, there are surgeons such as Dr. Stephen Paget, really based observation on many, many patients, proposed a theory called seed and soil hypothesis. So this suggests that when tumor cells disseminate from the primary site, it doesn't have any direction when they are disseminated, but they arrive at different organs with an equal chance, but only in those organs that provide a congenial environment to the cancer seeds, the metastasis will occur. Of course, different cancer seeds may have different preference in terms of which soil they will to grow. Right? So you have to have the compatibility between the cancer cell properties and the environment, microenvironment properties. However, what's unclear to this date, many scientists and clinicians are doing this research, but we are still not very clear about what is the congenial soil, right? Can we prevent the cancer cell to grow in certain organs, or is there a general way to prevent this seeding process altogether? So this is one of the, again, another central topics that's been researched at many different labs. In a later session, I will touch upon this a little bit more. And the new insight from recent literature is maybe metastasizing to one organ is not the stop. And rather, there's maybe when patients manifest different metastases, some of those may actually come from other metastases, right? Rather directly from the primary tumor itself. And this is a study published a few years ago in preclinical models demonstrating this metastasis to metastasis seeding. There's important implication of this because it may suggest that we need to kind of monitor metastasis more closely, especially when the first metastasis appear. Okay, and in the real world, many times there's the bone metastasis first appear in ER-positive tumor patients, and it can be very well controlled with different treatments. And the patient may live with bone metastasis for a long time, but sometimes all of a sudden the relapse occur to many different other organs. So how to control tumors within one organ may be clinically also beneficial, and that's something that we need to research as well. All right, so I'd like to switch gear again about this, what cancer cell, which subset of cancer cells, and what other cell types may contribute to metastasis. And some of you may have heard this concept called cancer stem cells, right? Cancer stem cells have been in the news for quite a long time until very recently. And so when we talk about cancer stem cell, we're talking about a subset of cells that have the ability to reinitiate the tumor, so to reconstitute the tumor completely. So that subset of small number of cells have the ability to reborn a new tumor, okay? So give birth to a new tumor. The very early literature suggests markers such as CD44, CD24, or ALDH. These are the cell surface markers that scientists use to distinguish this subset of cancer stem cells. And they did experiments like shown here. They put these cells into different sides of the animal. So you're looking at one mouse, right, lying. You see a right circle on one side of the mouse, and there's should be another circle on the left side because both sides received same amount of cancer cell. It's just the right side received this CD44 positive, CD24 negative cells. The other side received the rest of the cells. And so there's a lot of paper showing that some the CD44 positive, 24 negative cells can have the ability to generate a tumor, regenerate a tumor, whereas the other cells do not. Okay, so these are this is a concept where the concept of cancer stem cell come from, and has been the center of attention for quite a while. So before we talk more about cancer stem cell, I'd like also to introduce another process, EMT, epithelial mesenchymal transition. Some of you may have heard about that, and this is another concept that's been linked to metastasis in the research world for a long time. And it also makes a lot of sense because from just the term, you know that this is a change of cell state, okay? A mammary tumor, breast cancer, is epithelial tumor by our origin. So our mammary glands are made of duct, right, of mammary epithelial cells. Epithelial cells wrap around to make a duct and make a lobular, and that constitutes the mammary gland. And it is those epithelial cells gave rise to breast cancer. So breast cancer, by nature, they are from epithelial cell. And epithelial cells, the major characteristic of that is it has a very tight cell-cell junction. And it is so connected to their neighbors. So they hold hands tightly. They form a sheet because one of the major functions of them is divide, right? Our inside word from outside word. So they are not supposed to move. So for metastasis to occur, as you can imagine, if you are always held by your neighbors, there's no way you can go, right? So it has long been postulated that these cells need to lose their connection with their neighbors. And they themselves need to also change their shape from this cuboid, this square-like cell, to a spindle-like, because spindle-like cells are more likely to migrate, to invade other tissues. So this process is called EMT. It was a naturally used program in our embryo development when some cells need to move to another place to generate other organs, but somehow hijacked by the cancer cell. And they become, through this, the cancer cell may become migratory. This process has been equated to metastasis for a long time, okay? And many, many studies focus on this. Okay, we talk about cancer stem cell and talk about EMT. And just about like 15 years ago, there are paper published kind of connecting these two things, make it even more concerning because this paper showed if you change cancer cell, let them undergo this EMT process. At the same time, they also acquire cancer stem cell properties. So this is highlighting even more that how EMT may be important because not only you gain the migratory ability, right? You also gain the stem cell property. The stem cell property being able to regenerate a tumor, right? So these two crucial requirements for metastasis can be gained through one process. So this make this EMT even more at a central stage, central position of metastasis research. Okay, so this is the old literature. Okay, now I'm going to tell you a little bit more what we learned recently. So this has been kind of challenged, this hypothesis. These two papers using genetic preclinical model, they abolish the ability of EMT altogether of cancer cell, but still get metastasis. Okay, they still get metastasis. So why is that? So people start to question if EMT is what really necessary for metastasis. There's a lot of debate centered around this topic until people start to kind of look across all the data supporting EMT, negating EMT, and try to really synthesize the knowledge. they start to realize, okay, it's not about you being a epithelial cell or a mesenchymal cell. It's rather the ability to change, to swing back and forth between these two states that's really important for metastasis. So this is a word we call plasticity. So the plasticity of the cells that can, when they need to be an epithelial cell, they can take the form of epithelial cell. When they need to migrate, they can swing back to mesenchymal state and be able to migrate. So those cells are the ones really responsible for metastasis. So this changeability, plasticity, is the key property of cancer cell to give rise to metastasis. And correspondingly, as you can imagine, now in looking for drugs inhibiting metastasis, one way to do that is to kind of lock the cancer cells, not allowing them to swing back and forth. But there's also other important implication of this. When cancer cells do not need to completely lose their neighbor, their connection with neighbors, but they can still move. Then one way to move is to move together with your neighbors, right? So you don't have to move alone. You can move together with your neighbor. So there may be a group of cells that move together. And they don't need to have this complete EMT process. They can partially lose it, but still maintain some plasticity. And they also have the ability to hold their neighbors hand in hand and get to the blood circulation as a cell cluster. So this is called collective invasion. This is work from Dr. Andy Ewald's lab at Johns Hopkins. And when they move together, when you get into the blood circulation, they maintain as a cluster. This is called circulating tumor cells, CTCs. You must have also heard about this, circulating tumor cell clusters. They move together, they enter the blood, they maintain as a cluster. And it turned out these clusters of CTCs are more likely to see the metastasis than the single CTCs. Okay. People have shown that if you can find cluster CTCs in the blood, and that is a worse news, and that will suggest the outcome may be worse. And even more than that, now people, by looking more and more into the blood circulation of the transition, the cancer cells in transition, we begin to realize that not only the cancer cells can hold hand in hand, move in clusters, they can also recruit other cell types, the immune cells, fibroblasts. So in the blood, you can find these clusters that not only have cancer cells, but also have other cell type. And a lot of research are focusing on that phenomenon. I'm trying to study if the different participants in this village, in this cluster, are playing some roles in sustaining the cancer cell. If we can maybe break this cluster and dissociate them and see if we can achieve better therapeutic outcome. All right, so I know that we are having a lot of information. I'm going to try to slow down. We have 2 more sessions to go, and I would love to take any questions if you have. Maybe a few slides about exactly how metastasis may occur after they arrive. So we talk a lot about when they leave the primary tumor, when they're in the blood circulation, but how about after they arrive in different organs? That's even, I think that is an even more complicated question because they are mammary gland cells, and now they're in a different environment. Let's take a bone as an example. And this is the osteolytic bone metastasis, how they look like in the clinic. You can tell there's a lot of foci where the bone mass is reduced. You see this shade. That causes pain, sometimes fracture, hypercalcemia. If it happens in the spine, it can cause spinal cord compression. This is very painful diseases, but when they are diagnosed in the clinic because of these symptoms, it's usually already in a pretty late stage. And if you kind of zoom in into what you saw in last slide, to a molecular level, okay? To a molecular level, you're looking at the bone section. You're looking at those pink regions are the matrix, bone matrix, the hard part of the bone. A lot of bone marrow cells on the bottom of the screen. You're looking at tumor cells already become pretty aggressive, and that they are moving into the new space of bone marrow. And if you look at these arrows, you can find a multinuclear osteoclast cells. The osteoclasts are bone-dissolving cells, okay, the cells that chewing off bone matrix. And they are needed because we constantly have bone turnover. We need to tear down our old bone, generate new bone, and the osteoclasts are the ones that are help us tearing down the new bones. And in this case, they somehow are hijacked by cancer cells. Cancer cells find a way to utilize them, to take them with them, and they can see that they move together with cancer cells in a certain area. They start to adhere to the healthy bone and dissolve the healthy bone. And that will benefit cancer cell growth. And as we know from a long time ago, this is called a vicious cycle, because as you're chewing down the bone matrix, the bone will release some growth factors that reciprocally activate cancer cells, further activate cancer cells. So that becomes a vicious cycle. In fact, the current therapies in the clinic to treat bone metastasis are not targeting cancer cells directly. So they are targeting osteoclasts. So their function is to stop the osteoclasts, not let the osteoclasts do things that are favorable for cancer cells. So stop them so that the bone can be strengthened and the cancer cell can be better controlled. So this is a very typical situation where you have cancers that evolve a new ability. And this new ability is new to the cancer cell themselves, but this new ability involved already existing cell type, already existing mechanisms in the other organ. Some more new insights recently. We know that now the cancer cell can have a very close interaction with bone microenvironment. Shown on the left in that fluorescent picture, you're looking at the green island of cells. That is a microscopic metastasis, the green cells. They're embedding themselves in the bone. The red cells are the cells that make bones. So in this early phase, osteoclasts have not come yet. So then before osteoclasts are engaged, you actually already have a lot of interaction between cancer cells and the bone cells, and the very intimate interactions between cancers and bone cells. That actually provides some therapeutic opportunities, because we can separate, we can disrupt this crosstalk early on. That may represent another way to prevent this cancer cell from thriving. And we also can take advantage of this knowledge and to make a new drug targeting this cancer cell that is embedded in a specific environment. For instance, we can link our antibody with denosumab, bisphosphonates. So the antibodies will target cancer cell, and the bisphosphonate will keep these antibodies stay longer, reaching a higher concentration in the bone, so that they can do a better job to eliminate cancer cells. So this is something Baylor and the Baylor College of Medicine and the Rice University are collaborating, trying to come up with this new class of drugs. All right, this is the last session. We are 30 minutes into the talk. And this is a more kind of discussion. I don't have more picture to show, but rather we can make it open discussion. I'd like to maybe lead the discussion by first showing, I don't need to show all of this to you. We all know the current therapies. And we all know these current therapies work, but not perfectly to the metastatic breast cancer. And a lot of these current therapies are based on the characteristic of primary tumors. We recently also started to have antibody-drug conjugates, as we just heard from the last talk, and it worked very well, but there's still room to improve if we know more about metastatic tumors. The point I want to make is we always try to kind of make primary tumor metastasis equivalent. We kind of, all the therapies, we never really consider metastasis-specific treatment. And we never really have a powerful tool to target something that uniquely evolved in the metastasis for some reason, for some reasons. And I also like to mention immunotherapies, which is very important. And the reason for that is, immune system, as I already mentioned several times in the previous talk, right? Either you don't have enough active cells to detect your signal, or you have something else kind of maintain the dormancy of cancer cell. But either way, if we can overcome those barriers, our immune system will still work for us. So that's a very important message, I think, to take home. And that's the message we learned from a lot of recent literature. We used to think our immune system already gave up, but it's not the case. So many success, including ADCs, and including antibody-drug conjugate. A lot of efficacy of ADCs based on our immune system. If you have functional, competent immune system, ADC will work even better. So our immune system have been trying, never stopped trying to fight cancer. And it's my personal belief that if you ultimately have something that can kill all cancer, it's our own immune system. Because only the immune system is evolved to have the volatility, the power, the changeability, the ability to evolve that can catch up with the cancer cells. That's why when you see immunotherapies work, oftentimes the effect is durable. It's not like kinase inhibitors, not like other therapies. Sometimes you have resistance develop, right, sooner or later. But when immunotherapy work, oftentimes, not only in breast cancer, but also in other cancer types, oftentimes that effect is durable. So that's something in the horizon. But then given all of that, why so difficult to treat metastasis? Why are we still failing, in many cases? I think one thing I kind of already touched upon is metastases are different from primary tumors. And that has to be acknowledged, I think, when you design new treatment for metastasis, especially metachronous metastasis, metastasis that develop after primary tumor resection. Okay? The metastases that have undergone independent evolution process independently, right, from the primary tumor. So they are different. We cannot simply extrapolate what we learn from primary tumor to metastasis, especially after this long time. And metastases are heterogeneous. Metastases in the bone and metastases in other places may be different, right? So because they have evolved to adapt to this different environment, and they develop different, for them, skill set or toolbox to do that, and to disrupt that, we may need different strategies. And metastases are often therapeutic resistant because they have been treated. They survive all the previous treatment already. So they inherently have some resistance to begin with. Then, why so difficult to study metastasis, right? We complain about we cannot effectively treat metastasis. But what preventing us from finding new drugs, finding new treatment? Availability of tissues. Primary tumors are very readily available. They are surgically removed, they are biopsied. We have a lot of primary tumor tissues available for analysis, but not so for metastasis. And so I think it's extremely important for us to have a large tissue bank for metastasis to look at, especially microscopic metastasis. I know that NBCC and DOD are supporting big campaign trying to get those microscopic metastases. I think more of such effort need to be initiated so that we have more knowledge about these cancer cells when they are still hiding, when they're still in their hibernating status. What's their vulnerability, right? We need to learn from the real tissue, not just the preclinical models. But even for preclinical models, we are still lacking the relevant, faithful models. We kind of simplify. We use simplified model. We try to generalize what we found in the models to the clinic, and oftentimes we find it's not completely the case. So we definitely need to be more innovative in creating models that match the clinical reality. And finally, even if we go through all of this, preclinical phase, when we reach the clinical stage, it's very difficult to design the clinical trial. And as the reasons are shown here, we can have a discussion about that. It's relatively easier to treat already established metastases, especially when the current standard of care all fail. Those are simple kind of choice for metastasis for the clinical trial, but not so much if a patient do not yet have an overt sign of metastasis. So it's difficult to justify clinical trial on patient, even though we know many of them later on may develop recurrence. There's a lot of things that are preventing us doing a clinical trial. We need to have ways to identify high-risk population. We need to be able to detect microscopic metastasis as a criteria for treating patients, and then we need the treatment to be low toxicity in order to treat a large population of patients to get statistical power enough, and especially for patients without the sign of disease. So all of these are barriers right now in front of us, and what we are trying to do very diligently is to find ways to overcome these barriers. I think we should unite. As Josh mentioned, I think scientists often kind of work in their own lab. If they don't get input from you guys, it's very easy for them to become a doctor of mouse, a doctor of, and so we need real world input from patients, from clinicians. I think all of us should have more opportunity to sit together to kind of exchange our thoughts, to know exactly what each other is doing, and we need to have your minds to kind of decide. And especially on the important turns, which way to go. So that's exactly what we are trying to do, and that's exactly why I'm here. All right, so I'd like to stop. I have been working with a lot of people, including a lot of patient advocates. I think it's a great honor to be here again. I'd like to stop there and be happy to take any questions. Thanks.
You can stand there and answer questions. First of all, I just want to thank you, Sean, and I want to thank you, Josh, for giving us so much information that is really, really helpful, and acknowledging the patient advocates, because I know from having worked with you, they are an integral part of your research. And anyone who has taken Project Lead, I know that you understood every word that he said. For those who haven't taken Project Lead, you might want to think about it so that you can get up to speed and work with more researchers. So does anyone have any questions?
Hi, I just had a question about the differences between denosumab, obviously RANKL inhibitor, and bisphosphonates.
Yes.
And if you think one has a better use than the other, and what that would be, because it's a question I'm often asked, and I'm never quite sure how to answer it.
Yeah, I know. So to my knowledge, in terms of treating already established bone metastasis, if the bone metastasis already diagnosed, there's no significant difference between the two. In terms of preventing bone metastasis, there's data to show that postmenopausal women taking bisphosphonate in the adjuvant setting before metastasis has protective effect of bone, not only bone metastasis, but also metastasis to other organs. That data is pretty well established. But that data was not, the same thing cannot be said for denosumab. So bisphosphonate has this protective effect at the adjuvant setting, but not denosumab. So I think the study is still ongoing. This may change over time. So I'm also very interested to see the future results of this.
You said bisphosphonates and other organs?
Bisphosphonate lower the risk.
Yeah, for bones, but
Also other organs. Yeah, not less significant than bone, but also other organs.
what are the other organs?
The other organs, it's not defined. It's just anything outside the bone. So the reason for that, we have explanation, although we don't know if it's true, is the metastasis seeding, right? So if you lower bone metastasis, that's the first step of metastasis, and you may also kind of slow down further metastasis from bone, right? So that's the hypothesis.
Mostly ER positive.
Yes, but in this case, it's not just ER positive. The lower the risk is, I think, similar to both groups. That was like the data like 8-10 years ago. Yeah, also presented here at San Antonio.
If you're going to ask a question, please make sure you have a mic because there are some people that are watching this virtually. So just to make sure that you include them, that would be great.
Sorry, just one other quick one, and that is that a lot of people, I think, will probably have the same question, and that's that you say the immune system, and I think many of us feel this, is the key to perhaps dealing with cancer in the future, which makes perfect sense to us all. And of course, the terrifying thing for us is it's about the first thing they destroy with treatment. And this is can be very conflicting for us. I'm sitting there thinking, how do I get the right balance as I'm seeing neutropenia come again and again, and various metabolic things failing in different patients. So I just wondered, how do we deal with this?
Yeah. You're raising a very important point. I think the de-escalation of treatment these days is also a very important question. Kind of try to minimize necessary chemotherapy, realizing it may not just do good things, it may also do very kind of adverse things, and how to replace chemo with targeted therapy and with other therapy. We just heard the previous speaker talk about replace chemo with antibody. So that all is coming from, I think, similar avenue. We all realize we need to keep a very functional immune system. And that said, some low dose chemotherapy, in fact, have immunostimulatory effect, meaning if you use the chemotherapy in a lower dose, sometimes the chemotherapy can kill not just cancer cells, but also some bad immune cells so that your immune system can be rejuvenated. Yeah, right. So that needs more research, definitely. Yeah.
This isn't my question, but I do vitamin C IVs and ozone IVs to try and keep my immune system from getting too damaged. But my question was, I talked to a lot of patients over time, and they are paranoid that a biopsy will cause metastasis. What's your feeling on that?
Well, I don't. Current data do not support that. I think we don't have data to show there's biopsies. I can see where the concerns come from, right? But there's no data to support that.
Hi, thank you very much. I had a question regarding your comment about smoking and how that may awaken cancer cells. Is that, you were also speaking at that time about lung cancer. Is that just in lung cancer or is that breast cancer as well?
That particular study is metastasis of breast cancer in the lung. So that is for breast cancer. So I think the clinical data supported there's a significant higher risk of metastasis recurrence in smoking patients. I forgot the exact magnitude. There's some increase. It's not as dramatic as it's not as dramatic so that everybody know it, right? But it's a very significant risk.
Hi.
Yeah.
Okay. My question. Okay, I am on a clinical trial at the moment, not myself. I'm the consumer advisor for an immunology trial, and we're using TILs to look at sort of targeting treatments. And we've been using it in metastatic settings, and the next step potentially is to start moving immunotherapy into the early stage settings. How do you feel about that moving forward?
I'm personally very enthusiastic about that. I think that's to me at least, that's the right way to go. Being, a lot of the hurdles we're facing is not that the immune system are not doing the job, it's they are doing the job. There's also cancer cell evolve this mechanism to kind of dampen their function. And so if we can identify the right process that we need to intervene, I think for many patients, we can still reactivate the immune system at different stages. In fact, in early stages, it may work even better. That's my belief. Yeah.
I have a quick question about the mouse models.
Oh, yeah, here.
And, I know we torture a lot of mice by giving them cancer, but now we're breaking their hind legs. Like, how are you doing this in any kind of... Right?
Sorry, can you...
So we're breaking the hind leg of the mouse to get these... How is that being done in any kind of humane way? I'm just like...
So you just have to use a lot of anesthesia procedures. Yes, it is a painful experiment. But we try our best to make sure that the pain is minimized.
Okay, I think that we are over time. I want to thank you very much, Sean and Josh, and for all of you that are here. We want to thank you so much for coming, asking your questions. And if you want to learn more, think about coming to the National Breast Cancer Coalition Summit, where you can learn from many, many experts in the field. Michelle, would you like to say anything? Okay, thank you very much.